Okay, so depending on how you count, because we've had Mountain Day and various cancellations, this is the 17th day of the semester. This is Operations Research. I'm Professor Miller. We have two guests with us from the Northern Berkshire. Is it Community Coalition? Okay, good. So I was just talking with Brett, who I just met right now, and Amanda. I think we met at that epic race where I came in first in my age group. And this is I want this on video. Oh no! Yeah, come on, move over video. Yes, so I came in first. Yes.
You came
yes.
first.
Excellent.
Yeah.
Excellent. And you'll talk to people about how they can eat healthy, work well, and be like me.
Sure, absolutely. Well, we'll do that. I'll do some appointments later. By appointment, we'll do that. So as Stephen said, thank you very much for having us. My name is Amanda Chilson, and I have two roles at the Northern Berkshire Community Coalition. I'm the Mass Emotion Coordinator, and I'm also a community health worker. And I'll be here wearing my community health worker hat today. And I'll let Brett introduce himself, and then we'll get into why we're here.
My name is Brett Beatty, and I work at the Coalition as well, and I am strictly a community health worker at the Coalition. So that's my only hat.
So as Stephen said, we are here through the Coalition, but we work under a grant called the Berkshire Partnership for Health, and that originated from what's called the Prevention and Wellness Trust Fund. And if you turn to the back page, so the Berkshire Partnership for Health, that's our logo. So when you see this, you'll know kind of what it pertains to out in the community. And it's county-wide, so it's all throughout Berkshire County the grant runs. But the PWTF, or Prevention Wellness Trust Fund, is a grant that provides more than $42 million to 9 partnerships throughout the Commonwealth. So Berkshire County is one of the partnerships to receive that grant. And the purpose of this, and kind of the whole aspect behind it, is we're supporting evidence-based interventions, both in clinical and community settings, to reduce healthcare costs. Basics about the overall trust fund here. We're decreasing preventable risk factors, reducing the prevalence of preventable health conditions, and improving management of existing chronic disease. So the purpose that this money was given to these communities is to use this information and kind of run with it out in the community, both in the clinical setting and in the community setting, based on different interventions. If you turn to your next page, you'll just see who's at the table. So the important piece to know is this grant. So we then took it and created the Berkshire Partnership for Health. It's a county-wide grant that the Berkshire Health Systems received. The important piece is we had to have both clinical and community members, community-based organizations at the table. So this next page kind of shows the partners at the table around Berkshire County. So we have doctors' offices, we have the hospitals, our major hospitals in Berkshire County, as well as the Coalition, our YMCAs, elder services, just various places that work with the population in the Berkshires. You'll see a few others on there as well, the Public Health Alliance, the Tri-Town Health Department, and that. And then that being said, we then, making it kind of our own, we have 4 intervention strategies that we specifically focus on here in Berkshire County. And if you turn the page, you'll see 4 squares with the arrows, and I'll let Brett kind of go over those 4 interventions.
Awesome. Thank you.
Yeah.
So from a needs assessment, like a Berkshire County needs assessment, they identified 4 preventable diseases that would have the most effect if we targeted those. So those became our 4 interventions for the Berkshire Partnership for Health. And the four interventions are, a high blood pressure monitoring program. It's called Get Cuffed.
And that's in hypertension.
It's in hypertension. It's a pre-diabetes program, so people who are not yet diabetic, but their blood sugars levels are rising, so they're on their way to becoming diabetic. So an intervention there to prevent them from crossing that threshold to becoming diabetic, and that's through an education class too, a free education class. And then there's tobacco cessation. We have really high prevalence of tobacco use in Berkshire County, especially in North County, and so connecting people to a tobacco treatment specialist, nicotine replacement therapy, and helping them try to quit. So it's the most successful way to quit right now is seeing a tobacco treatment specialist and getting on nicotine replacement therapy. And lastly, we have a high population of older adults, so a falls prevention class for older adults. Actually, me and Amanda both teach these in the community. So it's just trying to take that subject of falls and break it down in more controllable pieces, promoting exercise. Exercise is focused on building balance, flexibility, coordination, and strength. And then also going through your living environment and your daily routine and seeing where you're exposed to fall risk activities or habits that may expose you to more falls risks. So it's a fun class that we teach. If you look on that page that has the 4 squares, this kind of explains how those interventions work. I'm just going to go over how, like it says community, and that's where me and Amanda are at. We're at the community level. So like for smoking, it says promoting smoke-free environments. We don't work so much on smoke-free environments. We try to work with smokers and get them in to see a tobacco treatment specialist. But then on the clinical side, it says implement United States Preventive Service Task Force screening and treatment guidelines. So like it only works when you have people in the community trying to connect people to a clinical setting, and a clinical setting connecting people to community-based programs. So it's a crossover between, it's not just sending people straight to, everyone is not going straight to clinical. It means that clinical is also referring people to community-based programs, whether it be someone who needs, improve their health by doing more exercise, then the clinical program is referring them to the YMCA, and vice versa. If someone needs some support with raising their family to become more healthy, to reduce their stress levels, the clinical is referring them to Berkshire Children and Families or Northern Berkshire Community Coalition's Family Center. So it's only working when we're referring in both directions, and we're reaching as many people as we can, both in the community and in the clinical setting. So if you can look through those 4 diagrams, it says what we're doing. The Get Cup home blood pressure monitoring program, that's hypertension, and then there's also implementing the new guidelines for JNC8 in the clinical setting. And then home safety and modification from fall prevention, that's community-based, so there's a home safety assessment that another CBO does with our grant, and we teach the matter of balance class to help them get moving, look at falls differently. And then in the clinical setting, they're just implementing the guidelines for a clinical setting, and then also referring to the matter of balance classes and the home safety assessment. And the National Diabetes Prevention Program, that's a nationwide program, and we're trying to get people to join that. It's a more comprehensive program than just a short 2-day pre-diabetes class. And then in the clinical setting, they're implementing the same kind of screenings for diabetes and things like that. So here you go.
So I think the important piece about that is our job is as community health workers is to be out in the community and try to provide information about preventative health and what are the resources that are out there. And so we are out at food pantries and thinking of what community health workers do locally. We have them across Berkshire County, but we're at the food pantries, we're at our meal sites, we're really trying to reach the population that might not take it upon themselves to get into preventative health, whether it be seeing a primary care physician, and we'll connect people to primary care physicians that don't have them. We'll help people go, find out where they can get insurance and how to work through that process of getting insurance. We've been going to some of the neighborhoods, some of the community centers in the neighborhoods, kind of all over, wherever, and coming to, places like, Williams, or we've gone to the Carver Dental, different places where we can do presentations to let people know what we do, so the word starts to spread that there are these resources out there, and you don't have to go to your doctor, you don't have to go up to the hospitals to get these, but a lot of these are out in the community. Our diabetes classes, we're trying to move them out into the community. Our matter of balance classes, we teach at community centers or at the YMCAs. The same thing with our tobacco treatment. We're trying to bring some of the group classes out to the community. So really, in order to do the preventive health work, it's really building that relationship with a person. So we'll spend a lot of time just talking with people, figuring out where they're at, what's going on, connecting them to other resources, and then eventually that kind of circles back into some of the work that we're doing around health. But it takes that moment to build lots of moments, to build relationships, to have them trust us and know that that we can help them. And how it works, as well as at the clinical setting. The doctors are running some of these tests that Brett referred to right there with their patients, and then they're referring them to our care coordination team. And that's like our central hub. They're located at Berkshire Health Systems, but they work with community health workers and patients all across the community, all across the county. So doctors will refer them to what we call the hub. That's just the name that we decided to make up. It's our care coordination team, and then they'll match them to the prevention intervention that works best for them based on what we're working with. And then we also, Brett and I will also be making referrals out in the community. So we'll gather information from the people we see. We have them sign a consent to let, so that we can be in touch with them and we can share their information. We work with some patient information as well. And then we refer them to the hub. And so then the hub, again, places them in where the best location is. So we kind of have this network working to help create and bring health into the community. What we also brought for you is some numbers. I know this is a math class and a research class, and you work with a lot of numbers. So what we'll leave with you is a few things. One of the things we have to do for reporting, a lot of the work that we do, we can catch it in numbers, but we also catch it through success stories. Some of the work that we do, it's really hard to show a numerical statistic for a person that's quit smoking, in the sense of their story is just so much greater. Their background, when we talk to them, we find out all that they've had to go through, and the small steps we've helped them get through to eventually want to quit smoking is large, but it's really hard to capture that in numbers. So we do have some success stories that we keep on hand, taking pictures of people and letting them know, and kind of capturing those stories, as well as we have specific data so that we have to report to the Department of Public Health. That's part of our funding comes to them, and so we have to have specific numbers and specific targets. So I'll let Brett kind of go over what our monthly reporting looks like. That we do, yeah.
These are copies for them, right?
Yes, I can hand them out while you're talking.
Okay, great. Just leave me one.
Yep. Here's 2016.
Sweet. So Amanda's going to be passing around what we call our monthly milestone reporting. This is us reporting on our numbers for people we reached, interventions that we referred people to. And just to go back a little bit, Amanda was talking about stories versus numbers. And this kind of puts it into perspective a little bit for you. Sometimes you see someone over and over again and talk to them over and over again, and you build that relationship, and you still don't get to report that number until they are referred into your intervention or things referred to another CBO or to a clinician or something like that. So it's sometimes a lot of legwork and a lot of hours spent, and then it's just one slash on a report at the end of the day. So it's really important to also share the story of the work that we're doing, the community that we're reaching, and the changes that we're trying to promote, as well as the numbers. I will speak for myself. I'm not a huge numbers person. Hopefully you guys are. I'm a people's person. That's my strength is talking to people, hearing their stories, listening to them, and then trying to connect them with things they need. That's why we're good at what we do. But we do try to capture our numbers as well. So, looking down at the sheet in front of you, the first intervention there is tobacco use, and it shows us how many people we've got to fill out a ready to quit screening. Look at July is 1, August is 1, September is 1, October is 8. That's we held some kind of event in October at a food pantry or a meal site, trying to promote people to quit smoking, and a lot of people took the screening tool to see if they're ready to quit. And then if you look below that, it's number of clients referred. So out of the 8 that took the screening, 7 were referred to see a tobacco treatment specialist. But then I want you to look at the last number there of clients encounters. No, it's not the last number. Client encounters receiving education. So we didn't report right in October. That's funny. But let's look at the end of it. 113. So 113 people received education. That means that we talked to 113 people at community locations. We were either trying to convince them. No, I'm skipped all the way to the end. Year-to-date total in tobacco. So we talked to 113 people in 2016 about quitting tobacco, the harmful effects of tobacco, told them about the resources available to help them quit. Out of that, 32 people were referred to a tobacco treatment specialist, and 35 people took the Ready to Quit survey. So that gives you the sheer number of how many people we have to, not that we have to talk to, that if we want to get people into these services, then we need to talk to a lot of people. And you can never give up. You always got to leave that door open. You can check back in with people and see if they're ready at a certain time in their life. Sometimes it's a little chaotic, a little stressful, and they're like, it's not time for me. And then you see them 6 months later, and they're like, you know what, I think I'm ready to quit now. So it's a lot of legwork with people and stories and following up with them. And you can kind of look down through all the interventions. It's kind of the same old. It's the same old pattern. Let's skip right down to diabetes. 2016 year-to-date total, 238 people we talked to, and I don't think that accurately reflects how many people we actually talked to. It's just how many we recorded. And so 238 people we talked to, 228 of those people filled out a diabetes screening. So is your blood sugar getting higher? Here's some indicating factors that your blood sugar is increasing. Screening. And then 17 were referred to a class or an intervention or a clinician to see somebody about, educating themselves about prediabetes. So a lot of number work there with not as much result as we want to, but I think that's what the community-based work is really trying to spread the news about it, trying to reach as many people as we can. And if we focused on the results, then I think we would have a hard time staying motivated, so we focus on the stories a lot.
And also, too, just to preface, this is a 4-year grant, so our first year was a capacity building year, which we spent a year kind of building who are the partners to be at the table, how's this going to work, what are the interventions, what are we going to do, what makes most sense for Berkshire County. So there's a lot of work, maybe like about a year and a half into that. So Brett and I have been really going strong. We're going upon 2 years of actually been able to be out in the community and doing this. And so I think, you spend almost the first 6 months figuring out, like, where do we need to go, who do we need to meet with, learning the language, understanding, like, what we need to be sharing with people, and then and how we can get them involved, as well as realizing a lot of trial and error. We go and there's so many people that are like, I don't have food for dinner, I don't have a house to live in. And so they're not there to really talk about their health in that moment. And so how do we help them get to those resources and then find out, how do we get them eventually thinking about their health, as that's super important to help maintain some of those resources. And then also, too, so we submit this information to DPH, as well as our care coordination team is also tracking numbers. And so once a month we have a leadership team. When all of the partners come together at the table, we meet. And a document is given about their, all the referrals that are sent to them, and the percentages of people that they are able to follow up with, that actually, then the percentage of people that actually partake in one of the interventions that they've been referred to, as well as the percentage that have been completed. And so again, you kind of see the higher numbers of educated, and then it goes a little bit lower for the people that screen, and then the actual that are actually referred, and then those that say yes, they want to take part in the intervention, and then even a little bit lower for those to complete. So we're always looking to, kind of build those numbers. And I'm happy to send, we didn't have our most recent leadership team meeting this month, but I'm happy to, share those numbers with all of you too, to kind of see what the trend is. As well as, I made one copy of these, it's a little bit thick, but I'm happy to leave this with you guys too. This is our most recent feedback reports from the Department of Public Health. So we submitted a lot of these numbers that we're sharing with you, and they then put it into some infographics and information to help understand, some of the work that's being done, the referrals that are being made, and the people that are participating in the grant as well. So I'll leave that for you. I think that's pretty much the information. We kind of want to give you a background, I guess, on some of the preventative work that's happening here in North County, as well as across Berkshire County. So hopefully that kind of painted some of the picture. It's large, so definitely read if you'd like to, up on it a little bit. Are there any questions for us about any of this? Yeah.
So, do you guys spend most of your time talking face-to-face with people?
Mm-hmm.
Or do you use technology with people, or not really?
No, we're out.
Can you just repeat the question? Because it's
Yeah, absolutely. So the question was, do we speak with people face-to-face, or are we using technology to do that? When it comes to the people in the community, the residents that we're trying to get into some of these programs and provide them with some preventative health opportunities, it's face-to-face. Yeah, with some of like maybe a meeting with our partnership, meeting with partnerships and our leadership team, we might use some technology in that sense to, connect with some of our other community-based organizations that are at the table, because there are a lot of things that are happening all over the county, and so it's tough to be everywhere all the time. So definitely to connect with our partners, yeah. But it's to build a relationship, it really has to be that kind of face-to-face interaction. Do you have anything else to add to that?
Yeah, I mean, I also like these people the people that we're working with don't necessarily have those resources. Like Amanda said, sometimes we're eliminating the most basic needs before we can even connect people to interventions. You're not going to convince someone to, even though it's counterintuitive, you're not going to convince somebody to stop smoking tobacco or using tobacco if their life is in crisis. If they're trying to get food on the table or food in their belly day to day and find a shelter or whatever their needs are. I mean, a lot of these people we're working with are their life, the way they're looking at it's in crisis daily. And so, it's really a fine line. So meeting them face to face gives us a better idea where they're at. And Sometimes it's like, no, we're going to connect you to the housing authority. Or no, have you heard about the homeless shelter, the Lewison House? It's connecting them to those resources and building that relationship and trying to eliminate some of those barriers to their health. Not having a house, not having food, huge barrier to health. Taking a pre-diabetes class when you have no home and you have no food, like secure source of food and no income, is really not top priority. So it's really about, if we meet someone, it's top priorities, or if it's someone who's ready, they're ready to engage in some of these health improvement classes and resources, then move forward with it. But it's really that kind of like gauge the conversation, listen to them, and then go from there. And usually that's not just in the first time you meet somebody. Usually that takes a couple times of meeting someone. You walk into a food pantry for the first time and you're not there to collect food. The name tag gives you away a little bit, but you need to be integrated into that community a while before people trust you. Now, after going to food pantries for a year or more, I walk in and I see multiple people. Hey, Vinny, how you doing? Frank, how you doing? People see that I know people in there, and they're like, okay, that guy's a good guy. And that's really the community, the relationship that you need to build first. So technology, although like telehealth is always a conversation, especially with rural settings, it's not quite there yet for the demographic we're working with.
Yeah, I have two questions. The first is, do you guys do any follow-ups with people who completed your programs to sort of make sure they aren't relapsing into whatever habits you're trying to prevent? And then just go ahead.
No. So the question was follow-ups. Do we do any follow-ups with people in our programs? And we absolutely do, depending on the intervention. We just did a Matter of Balance, which is our falls prevention class for older adults. We did a whole year of classes, and at the end of the class, when the participants actually graduate, they were always like, man, we really want to get back together, or we want to stay in this routine, because they're in this exercise routine, they have momentum, they're being active, they feel motivated, and they're like, how do we stay connected? How do we keep this going? So we started making these phone trees at the end of our class, and so people could connect to other people within the class, to go and walk in groups, or to go to exercise classes, or just be a social support for someone who's trying to make some changes in their life and become more active. And at the end of the year, we're like, we have all these phone trees. What are we going to do with these? So there's a week in September, the whole month of September is older adult awareness? Falls prevention. So there's a day in September, it's the 22nd, it's falls prevention. It's a National Falls Prevention Awareness Day. And so we decided to bring everyone together at a community location, and we had this like reunion for our graduates. And we did our exercises, we socialized, and it was a great way for people to reconnect, also reconnect with the exercises and remind themselves that, hey, doing exercise, being active, being social is very healthy for me. And I've let it slip a little bit, and I'm going to get back into that routine. So that's just one way that we've connected people. I'd also say that like going to the food pantries on a regular, you see the people that you did talk to about quitting, and they weren't ready yet, and you talk to them again, and they're still not ready. But you're kind of having this conversation about why they're not ready, or what's going on with their health. Like if they talk to you and confided some things in you, you're usually like, hey, how you doing? Like, how did that go? It's pretty basic, but sometimes it's something that not every individual is getting. People aren't getting that individual attention, that care, or that like empathy for their situation. So.
And a few other, like Brett said, with the face-to-face follow-up, as well as a lot of times we refer somebody into a program, the nurse. So for our Get Cuffed education around, taking home their own blood pressure cuff and monitoring that, the nurse that teaches that class will also follow up with them. So they'll be sent home with a cuff. They have a journal they have to keep for 10 days, taking 2 readings per day. They submit that to Berkshire Health Systems, and then the nurse follows up with them and says, here's where you're at. Things are looking good. What have you been doing? Like kind of like help them reflect and understand what's going on, or things aren't looking so great. Here are some next steps, for you. Like ER or doctors, or depending on the severity of it. So there's definitely some more work on formal and like a specific process follow-up that's happening, and that we're looking to kind of work on, because sometimes we feel that like we'll make referrals and we're like, we don't know like what's going on with people. We do have a consent that they sign, letting them know like we can follow up with them at any point. And so when the moment's right, we might just give a call to somebody and say, hey, how are things going? Did you check into whatever? Or we let them know what's going on. We help to schedule a lot of other events in the community as well, and so we'll let them know like what some of those events are happening, and hey, why don't you come participate, or this nutrition workshop would be perfect for you with your pre-diabetes. So in that sense, but we don't have a formal process, but it's definitely something that we've considered.
And I will speak in a little bit more. Follow-up's huge. I mean, one thing that happens with people who go see clinicians or any medical professional is sometimes they say, oh, have you been doing this? And they're like, no, I haven't, or I haven't been taking my medications. So that's written down in their electronic medical record as non-adherent, or I forgot the other term they use. But really what they're finding is that we need to find out why. We need to find out why these people are not taking the recommendation from the medical professional. And sometimes the community health worker is really used for that. So the hub will even task us back people who we met in the community, we signed up for an intervention, seemed really motivated, we sent in their information, the hub called them to coordinate a visit with a medical professional, and they didn't answer their phone or anything like that. And so then they're tasked back to us, and there's like, this person that you met here, follow up with your own discretion. And so we're going back out in the community. We run into this person and we're like, hey, the hub called you. What happened? And you find out their cell phone was like taken away or anything like that. There's all sorts of barriers. But it's really finding those people who fall out of the system too, because staying part of that, like checking in with medical providers and things like that is really important to maintaining your health. So that follow-up is happening. We're sending people to the hub, and the hub is also sending us people. So that's kind of the system right now.
And you had a second.
Yeah, my second question was, you guys have been mentioning a lot that you meet people in food pantries, and a lot of those clients have issues with housing or getting food, or more important issues than tobacco or diabetes. Have you considered like pivoting the format of your organization to aim at those challenges instead of having to move half the people you talk to into other programs?
You want this?
Yes, so that's definitely a big concern and a big conversation that we have with people. And there's a couple answers for that too. The reason that we were funded this opportunity, we were given 6 interventions that we had to work with. And so the only way to receive this funding currently is to really focus on those areas. So we do need to make sure that we're bringing those into the work that we do. And the piece about that is it's a nice opportunity because we get to introduce community health workers to Berkshire County, which I think we've had one a long time ago. We get to be out in the community and actually having some face-to-face conversations, and that helps us understand what are the real issues. And so we kind of do this assessment, or what are some of the real issues that people are facing here. And we do have a lot of organizations, and we have a lot of resources and social service agencies that are already providing these resources that these people have. They're just either not sure, there's so many barriers as to why maybe they don't access this. So then, you think, okay, community health workers can do more than just the clinical piece of things. Community health workers can be doing this and this. And so, and Brett and I will take it upon ourselves to help with some of those things, because in order to in order to help them with health-related issues, we have to break down some of those barriers. So it's absolutely a conversation, and later on, the whole point of obviously grants that you have is sustainability, and there's a lot of talk in the Commonwealth about community health workers being reimbursable and being written into some insurance policies and plans and things like that. And so I think down the road, community health workers have a much broader scale. I mean, in some communities across the Commonwealth as well that are doing this work, they have community health workers right in the doctor's offices. So they're there to be there to say, okay, these are the barriers, maybe help them if they don't speak English, get them signed up for housing and things like that too. So there's different models of community health work across the Commonwealth, and so this is just one model that we're doing kind of a trial with, if you will, out here, in hopes that we get the right numbers and collect the appropriate data and do the work that we're supposed to do and show that it's needed. It may be at a broader level.
I think another thing is that there's organizations that are doing that. There's organizations that are doing that. They've been doing it for a while. They're very good at it, and there's no reason to reinvent the wheel. You connect them to those organizations. You connect them to those resources, and then we can stay focused more on what the purpose of our work is. So that is happening. It is happening in our community, and there's lots of support for that. So we just connect those people to those organizations and resources.
So you said that your this program is evidence-based, and so I see numbers here, but I guess what influenced how you what influenced what you chose to measure, what you choose to measure, and then how do you use? Yeah, I guess that's the question.
So from the milestone report that you have in front of you, is that what you're referring to?
I mean, I guess there's this, but I wonder if there's any other numbers, any other like data collection. How do you measure your progress? I know you say that you have stories, but are there other ways that you wish you could maybe record what's going on, what your guys' work? Like for example, you know how you may talk to someone and then they're talking about housing. Like, is it possible to record that down? Like, here's how many people we talked to. Here's how many of them like are dealing with housing issue. Here's how many of them really are dealing with food insecurity. And these are the barriers that are mainly contributing to why they're not taking care of their health.
So the question is, are we recording all the data that we come in contact with?
Are you recording data?
How do we choose what to record? So there are other. We do hand in other data to the coalition that we work for around like people encountered or people assisted in the community and what we assisted them with them, because the coalition obviously has multiple different funding, and so if we're working with someone on tackling the barriers of finding a house, then we report that to the coalition, and we'll also report it with like people encountered. And there's a bottom part to that, those milestone reporting, and in 2016 there's quite a bit. So if you look underneath, there's coordinated Great American Smokeout event, Friendship Center Food Pantry. There wasn't really a good place to report that data, like that we spent time coordinating that event. Assisting a community member connecting to veteran services. There's not really a good category for it, so we report it on milestone that way. Assisted a community member connecting to mental health counseling. So we try to report, if we run into somebody and they need assistance, then we try to report it on the milestone as well underneath. As far as choosing, you were at ground up. So
well, the other piece to that too is for Department of Public Health, they want to see certain numbers around those interventions. So if we're spending our time, out doing this stuff and helping people, break down some of these barriers, we might document it on our own, but there's no good place, there's no structure, there's no process of where to report that information at this time. It's definitely something that we talk about in a lot of our community health worker meetings, as well as our leadership team. These are all of the things that are being seen out in the community. So, how do we capture that as well? And I think down the road, I think like Brett and I will note, we have, and we use our calendars for it. We have all our different events and the things we're attending and the places that we're going. And so we'll use that as at this place. I talked to so-and-so about food. I talked to so-and-so about housing. I connected them to IQ Healthcare. We did this and we did that. And then we'll note them here. But we don't have a formal process to say X amount of numbers or percentages. This month needed food or, we're food insecure. But definitely a good thought, because in order, those are social determinants of health as well. Those are from the broader areas. And the same thing with what we report is really driven by our funders. So the Department of Public Health, being a grant-funded position and doing grant-funded work, you really have to appease your funders. And so they want to see really the information about the specific interventions that we're working on. So they kind of delegated, here are the numbers that we want to see, as well as a partnership, we also maybe decide on a few extra things here and there to help us track the numbers that they want to see. So we track and like I said, that kind of that monthly report that we get, it shows how many referrals happened from doctors and how many happened from community health workers and how many happened from wellness screenings when the nurses are out in the community doing blood pressure checks and blood sugar checks and blood cholesterol checks, and then refer them here. So we have people, definitely from all areas referring people into the same, care coordination team and the same intervention team. So all of that specific data is captured within our central hub. And then we kind of go over that on a monthly basis to see where we're at, make sure that the appropriate numbers are being collected. And it's a nice reflection opportunity to say, wow, there's not a lot of people that have been referred to tobacco this month. Maybe this is something that community health workers focus at on specific events. So it's really driven at this point by our funders. But as it becomes something sustainable and it's not, so DPH driven, then we can kind of hope to expand on some of that information. Yeah.
So I will share one of the most painful data-driven stories of my life. One of my wife's cousins was getting married, so there was a bachelor party at the Brockton Rocks baseball game. It was also one of the worst baseball games I ever saw. Going into the bottom of ninth, if everybody from Brockton homered twice, the game would be tied. It was a painful day. We love the person he married, though. I bought him a pretzel because it was his party. It was a 30-minute wait to get a pretzel because the food concession stand had a piece of paper and they were manually writing down how many of each item was sold. I tried to tell them, just record how many trays of pretzels you get. All the trays have the same number. And then at the end of the day, just adjust based on the... And they just looked at me and go, 1. And so, this is an extremely important thing, is you have to go back and convince people that what you're doing is you're adding value. And you want an easy way. So is this something that we could help you with? Do you have good apps so that when you're talking with somebody, you can be quickly updating your records as to, I have talked to this many people on these issues, and just have this all being centrally processed.
Yeah.
I spent 4 years working in microfilm, microfiche. Look at an old Batman movie if you don't know what that is. And we had little pieces of paper that we had to fill out each day on how much work we did. But it was at least very fast. How many films in type A and type B and type C and type D did we bring back and forth? And so it allowed the bosses in microfilm to go to their bosses and say, this is how much demand we have, this is how many things are being used, but not be so onerous on us that, I'm sorry, I can't really help you right now, I have to do the paperwork. And I won't say if that's what I'm doing now at Williams.
No, I think that's a really good suggestion. I think that in any capacity, it'd be helpful to collect some of that outer data, because I think it really goes to show the importance of community health workers as well as preventative health. And having the opportunity to talk to somebody out in the community and not have to go to your doctor over for every single thing, because it's not always necessary and it's costly, and there's so many reasons to that. So I think that makes a lot of sense. And Sarah, too, I also want to add, I'm going to leave this, and this also shows a lot of the information that the numbers that we have to collect and then report back to DPH, and then, like I said, they kind of spit it back at us in a manageable, tangible way to better understand somewhat. I'm still trying to digest it, but other questions?
So you got the grant for 4 years with the idea that in those 4 years you'll become your own, you'll become sustainable enough to continue after that without funding from anything?
So the question was, we have the grant for 4 years, and with the hopes, with the thought of becoming sustainable and not have to have any of the funding after that. I think the hope is pieces become sustainable. I don't think that we have enough, again, because 2 years is really a short time to collect data to show this works. So I think we definitely have some pieces in the area. So for instance, our Get Cuffed and offering the blood pressure, cuffs. I think it's either happening or going to be happening soon, that'll be written into people's insurance policies, is those will be reimbursable through your insurance, now, to show that it's an effective, when people are at home, it's empowering. When they're able to take their own blood pressure and manage their own health at home and not always have to go to the doctor or nurse to do it, it's very empowering. I think we're working on that with, community health workers as well as our some of the classes we offer, looking to get those as to be reimbursable. And so I think I know the diabetes one is kind of the next one down the pipe. So I think in chunks, and in the hopes of reapplying for funding to have this go, I think there's talk about Prevention Wellness Trust Fund 2.0. So you're taking those pieces that are, and maybe not having to focus on those as much anymore, and introducing some of those more needed things and finishing up some of the other ones we didn't have a chance to. Do you want to add anything? Okay.
Okay, then I guess my final question would be, what would be most useful for us to do to help you?
That's a great question. So what would be most useful for all of you to help with us?
Or the subset of us that are
Yeah.
perfect.
Okay, right, exactly.
For the rest of you,
yeah.
It's just worthwhile to hear what are the issues of people who are actually working on the front lines in the real world. What kind of data do they need? How do they get it? What kind of problems can you attack?
I think this would definitely be something that if we had a little bit more time to digest and think about, we probably could give some more specific examples. But I really like the idea that Stephen presented, in the sense of how do we capture some of that other data, like Sarah said, that we can't necessarily through the grant, we don't have like maybe all the time and opportunity, but if we had a quick way, a down and dirty way to talk about the food, to talk about, access to doctors, to talk about those things, to really show some of the barriers that we're presented with before they can even think about prediabetes and even what that means and hypertension, all those things. Do you have other thoughts?
No, I think that I'm still thinking of ways.
So if we can definitely follow up with you as well, I think that we could hopefully break it down and be more specific about some concrete. It's always nice to have help, in that sense, as there's definitely a lot of different moving parts in the work that we do. Thank you very much for letting us come and speak with you and listening to us on a Monday morning.
All right, thank you.
Yeah.